Welcome to The Scope with Dr. K. I'm Dr. Kosinski. We're going to open the show today, as we always do, by stating that the goal of this show is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology when we can, but also out of GI as well. Today's show is a real treat for me. Our guest today is Nick Frenzer, a population health and implementation executive at Epic. For those of you who are not familiar with the electronic medical record space, Epic is the most significant EHR vendor in the country. I believe they have 51% of all the installations. As an exec of Epic, Nick brings experience leading large-scale software implementations around the country to his work coordinating the company's global support for population health strategy and execution. I heard him speak a couple of weeks ago at PTAC on this very subject. In 2020, he led a team that helped health systems add more than 92,000 beds to treat more patients during COVID-19 surges, and later focused on Epic's patient experience and interoperability efforts. Nick graduated from Arizona State University with both bachelor's and master's degrees in accounting, and worked in accounting for several years after his service in the U.S. Marine Corps. We thank you for your service, Nick. I had the opportunity to listen to Nick's presentation, as I said, at PTAC last month, where he presented on improving data collection and timeliness of data sharing of performance information with providers. We really grilled him at that meeting. But after listening to his presentation, I had to get him on the podcast. Plus, I've always wanted to have the opportunity to interview someone from Epic like Nick. I really look forward to this. Welcome to the show, Nick.
Thanks, Larry. Good morning, and I really appreciate you having me today.
Oh, it's our honor. Anyway, let's begin. Let's jump right into this. I always start my interviews with a guest by asking them to tell the listeners about themselves. How did you get to where you are now?
Yeah, thanks for the question. Certainly. So you mentioned my bio. My background was in the military, and I worked in finance and consulting for a bit before coming to Epic about 10 years ago. But my story in healthcare goes way back before that. I've always had a strong interest in understanding how do we take better care of people. I came from a family of not high means, so understanding how do we lift that tide is something that's always interested me. And I never thought I would get into healthcare necessarily, but it was after my time in the Marine Corps in accounting where I really needed a mission focus. I wasn't quite getting that in my work in accounting, nothing against the profession, but it wasn't there for me. And coming to Epic, I found an opportunity. There's nothing like going to a hospital or going to a clinic during a go live or seeing the software in use and seeing the impact and what you're doing for patient care. COVID-19 really changed my perspective as well. I moved out of much of the implementation space into focusing on product and strategy, which has been really exciting for me. And while I was in college, in graduate school, the VA was my healthcare system. I didn't have commercial health insurance. So understanding what that experience is like has also shaded a lot of how I approach our public policy efforts, our work with the VA and others to care for people that are not in or as fortunate to be in commercial programs like my family is in. So for me, it's a mission of how do we improve healthcare? How do we get to the point where we don't look at ourselves and say we spend as much or more as anybody else, but don't get those same outcomes? So that's really how I got here, is that mission and drive of getting in the car every day in the morning and thinking about what are we going to do to make healthcare a better place in the US and beyond.
Well, it's always nice to hear someone explain their own bio, because I learned so much more. Now I understand how you fit into population health. You had personal experience. There's no better example of population health than the VA health system. So, I see where this came from. So that's how an accountant from Arizona wound up being running population health over at Epic. Okay, all right, that all fits together. So now let's shift a little bit and focus on Epic. I think it's safe to say that Epic's the dominant EHR product for academic medical centers and hospital-based practices. I know there are a couple others out there, but Epic really dominates it. So this has advantages and challenges. So how does Epic view itself in this leadership role?
one thing about Epic, we're kind of a unique company in our approach. We're privately held, we're employee owned, and that gives us this opportunity to look in the long term at what we need to do, what's right. We don't have a quarterly earnings focus. We can make decisions on a 5, 10, 50 a year time span. And our focus at the end of the day is always on our patients and customers. And that's partly because of that employee owned and operated focus that we can have long-term strategies. But when we make a decision, we're thinking about what's the right thing for customer success and improving healthcare. That's where we feel that burden of leadership responsibility. And that mission that I mentioned before, that's what drives our focus each and every day. So when we think about leadership, we think about what is the right thing to do for healthcare. And we believe that we will be successful by focusing on our customer success and patient success, and ours will follow. So that leadership role, we really see as a responsibility to do the right thing at the end of the day.
Wonderful, wonderful. So does the fact that you are the leading EHR have a certain degree of give you an additional level of responsibility over the space? Do you take that responsibility?
Certainly, we've learned that if you're not a part of these critical conversations, there's a key perspective that's missing. And one of the things that we like to bring to this is we have a wide range of experience, as you mentioned. So many of the hospitals, about 70,000 of the hospitals in the US, or excuse me, 3,000 hospitals and 70,000 clinics in the US. So we bring that to bear. We also have experience in 15 other countries. So we have an ability to aggregate the voices in many ways, and certainly our focus is technology enablement in healthcare, but at the same time, bringing that conversation to things like the PTAC discussion that you mentioned to say, here's what we're hearing from all these different provider groups across the US. Here's what we're hearing internationally and help provide that perspective. But we feel a responsibility to be at the table to provide that perspective. Otherwise, we think that there's a voice missing.
I love hearing that. So you are the Goliath and you're surrounded by a bunch of Davids. So how does Epic's leadership view the myriad of such smaller EMRs that are deployed in the private practice space, specifically the specialist space? Is there a place for them, or is Epic just waiting for them to join larger systems and become part of Epic?
We recognize healthcare is an ecosystem. It's not all about us. It's about how are we providing that care for our patients. So for example, I work closely with ACOs and CINs that sometimes have 10, 20. I know a couple that have over 100 instances of other EMRs deployed. And we do provide options to help smaller practices and specialties utilize Epic, but at the same time, that's not always feasible. So that means we want to find ways to encourage and support providers regardless of their EMR, recognizing that our focus will be on Epic's customer success. But when I think about an ACO, for example, if I'm not enabling that ACO to communicate with their specialists on different EMRs and smaller practices, my customer is not going to be as successful. So we develop a lot of frameworks so that we can bring that data in, we can do real-time communication. If and when those specialties move to Epic, great. But in the meantime, sitting and waiting isn't a viable strategy, especially within population health, but as well as fee for service, where business relies on interoperability and support, regardless of what an EMR has a use case for. So it really is, we think of it, we often refer to the health grid, which is all the different interconnected components of what come together to provide that care. And we do that by communicating with other EHRs, regardless of size, regardless of who they are. We want to help make them successful as well, so that our customers are successful.
This is so critical. After 35 years as a provider, it would be so wonderful if we were all on a common platform where all the data was accessible. I lived in Chicago, had my healthcare at a couple of different academic and hospital-based medical centers, both used Epic. They were both able to obtain information from Epic everywhere. I then moved to Arizona, to Scottsdale, and the system down here also uses Epic. They were able to access the same information on me. What a wonderful type of environment to have, as opposed to in my practice life, we didn't use Epic. Our primary care doctors didn't use Epic. And we were constantly dealing with PDFs, incomplete pieces of information. and not being able to integrate it all together for care. So I've always had this vision that Epic could be sort of like Apple and allow other developers to latch on to its network through APIs. Is that happening as well?
Yeah, there's a couple pieces to that. So we have something called Showroom at Epic. It's actually showroom.epic.com that developers can come. There's a program that they can come into and access a sandbox, for example, and access open APIs that we've released for use in the community. So that's one way in which we enable people to do that. The other piece that I think is really exciting is the new QHIN development coming out of the TEFCA agreement. So for people who aren't familiar, that's the concept where, so for 15 plus years, we've had Care Everywhere, and more recently the Care Quality Network, where we share over 60 million records per week with non-Epic EMRs. Right. So that's been a huge success, massively important for patient care to get discrete data out to a GI specialist so they have that information and they're not pouring through a PDF or paying for something to read that PDF for them. The promise of QHIN is that we will have more centralized hubs to send that discrete information on a more broad basis so that it's something that is regulated, something that has good governance, good trust, because that's a component of this too, right? I have 3 kids that were born in an Epic system right down the street in Wisconsin at St. Mary's. And I'm less bullish about my data. I don't want my kids' data being shared or sold or sent anywhere where it should not be. So I think the QHIN structure is a huge component of how we do that and share that data. And at the same time, if somebody has a cool idea, we have open APIs that they can use to hook into that and provide that value to the healthcare system. So we want to be a part of that ecosystem and give people an on-ramp for how they can do that. It's a huge part of what we're doing today.
Boy, it makes me excited just to listen to all this. I didn't even know about QHIN until this interview. I'm going to break here for a second. If you've just tuned in, you're listening to The Scope with Dr. K. Our guest today is Nick Frenzer, Population Health Exec at Epic. Okay, let's shift a little bit, focus on your role. You're an executive for population health and implementation at Epic. So what does this mean? We pulled you as a subject matter expert at PTAC because of this position you have. What does this mean?
So like a lot of people, I wear a number of different hats, my main focus being in population health. So what that means at Epic, one of the fun things about population health is we have the quadruple aim, the triple aim. But if you ask someone about population health, I did this one time at a conference, I asked 20 people their definition of population health, and I wrote it down, and I had about 40 different answers. So it's one of the exciting things. For us, the way we have thought about this strategy, and I'll get into this a little bit more later, is it's a focus on health equity, interventions in care, and that could be primary, specialty, outpatient, inpatient, risk adjustment, and then moving that into value-based care and value-based reimbursement. So everything that comes outside of our traditional care models falls into our team and how we think about population health. And that spans into working with our federal and state partners, because 40% of people in this country are paid for by a federal payer. So ensuring we have a voice for how technology can enable their success. So I spend a good amount of time on policy as well, because it's so important. And then with respect to implementation, I help with oversight of our domestic US implementations. Now, some are smaller, adding on functionality for an existing customer that's been live on Epic for a long time, or sometimes it's a new group or a consolidation. And implementation runs the gamut, but the concept is delivering the best product that our development teams created that matches the business needs of what that healthcare organization or payer is trying to accomplish.
Okay, I do need to drill down a little bit on something you just said. I love the fact that the first thing that came out of your mouth was equity, because that really is so important today. We have to deal with the population. Okay, we got to treat everybody in that population equally, and we have to make sure that our population reflects the overall general population. I want to beam in on one thing, and it's the word attribution. One of, I've worked in value-based care for 10, 12 years now. One of our biggest challenges is attribution. How do you deal with that? Do you have any special tools for attribution?
Yeah, we do. First, I'll preface by saying anybody that has the magical solution to attribution, them. I mean, it's hard, right? We're talking
Yeah.
about tens, thousands, hundreds of thousands of people, and individually, who's the doc? Is it the oncologist who is really their primary care provider because they're a cancer patient? Is it the PCP they saw a month ago for a flu shot? There's no easy answer. But what we've done is developed tools that we can communicate directly with the payers, for example, and have a real-time attribution engine so we know what is the payer expecting of that patient's attribution to be. We support a lot of different models, but it's similar to quality measures, right? It's about what are you expecting? What am I expecting? There are going to be differences. I've been married now for 13 years, and I can tell you there's always differences in what the expectations of each party are. So reducing that friction is what we need to do, and we have tools to do that. But I think a lot of it is data transparency around if I disagree on 500 of my 60,000 patients, we now have a tool that can let payers and providers do that reconciliation. But at the same time, that reconciliation has to happen. And I think we all have to acknowledge that reconciliation is going to happen. Maybe AI can help us, but if we presume for the moment that we're going to solve it through, well, if I just send you this, we're going to be good. I think that's not necessarily realistic. So the tool is going to support that decision-making that is always going to exist in the very complex healthcare environment we have.
How well do the payers know about this attribution engine?
Yeah, so we have something called Payer Platform. So we have some groups that are using Epic for Tapestry for most of their business functions. But then Payer Platform is something where if they're not, we layer in an element of Epic so that they can communicate that. And we are pushing that attribution tool out to them so that they can do that. So I need the payers and the providers agree to do it. And then that Payer Platform allows the payers to send it and the providers can do it natively in Epic is the concept.
Oh, I may be tapping into you in the future on that. Anyway, let's move to value-based care. As I said many times, I heard your presentation at PTAC. So what is Epic's specific strategy around value-based care? If you could share that with me.
Yeah, the strength of Epic is that we're an integrated system. So we're one code base. We've never acquired, we've never merged. All the code is built in-house, centered around the patient. What that lets us do is when you look at a workflow for a provider, anyone in the provider system across an IDN, a CIN, an ACO, what have you, we can focus across the board. Now, one of the things I learned about value-based care and pop health moving into the space is you can't just focus on one component. So if we think for a moment about a commercial risk-based arrangement, you have to follow that downstream to where the care is provided, and then even further into how are schedules organized, how is the patient being contacted. And that's why I think we both love the value-based care space. For me, it's the future of healthcare because it's not just that you shouldn't silo your decision-making in that financial arrangement or in a care delivery opportunity, it's everything all together. You have to tie it together. And that's one area where Epic shines. But I recently heard a quote, which I thought, it isn't new, but it refreshed me. And that's if you really want to know what someone cares about, check out their credit card statement or their bank account. We invest our time in what we ultimately value. So if we don't pull together those pieces of what is the investment and reimbursement of how we're caring for patients, we're sort of just pretending to play at this value-based care game. And that's my focus is if you show me a value-based arrangement that you need to support in Epic, let's do it. I'm going to talk to you about your primary care and your specialty care structure and how you're scheduling your docs for 42 visits a day before we can even talk about your success in increasing your BCS measure by 5%.
I got a feeling you're going to get tapped by us again in the future.
Yeah.
So let's hone down a little bit here. Providers, patients, payers. I pretty much know what the benefit is to the provider. We just talked about the benefit to the payer when we had our attribution discussion. Let's focus on the patient. Why is it more valuable for a patient to be seen by a provider that's using Epic?
Mm-hmm. Yeah, so we have a huge focus on patient engagement. So my chart, many people think that my chart is Epic. I'll talk about Epic on a plane with somebody and they'll say, what's that? And I'm like, my chart? And they're like, yeah, that's it. That's our major focus for patient engagement. So for example, at the PTAC session, I appreciate your question about patient-reported outcomes measurement. So we do things, for example, we have something called Care Companion. So if I have a patient that recently had a joint replacement, I can bring them into the conversation, give them a day-by-day guide, educational materials, and have them record how their knee is feeling, how they're, use a device, for example, to pull that information in. My wife recently had a remote cardiac monitoring device that fed into her MyChart. And one thing that I observed working in the patient experience space for several years is there was this fear that patients wouldn't do it. They don't want to fill out another form. They don't want to go into an app and do something. It's not what we found. Patients want to be a part of the conversation, and we see this very high engagement. When we put a patient with a joint replacement, for example, in a care companion program, or if we push out something like an SF20, which is the questionnaire that's basically, how are you feeling? Are you exercising? Those types of things. Patients fill them out. Huge compliance with that. Then we get that to the provider in real time, lets them do decisioning or maybe reach out to that patient what they feel is appropriate. And then, of course, we can't forget about registry reporting and other pieces. So then it reduces the burden on the provider system to do all that. But I think the key is thinking about enabling the patient. Most people have smartphones today or some access to MyChart. That's great. And in the cases where they don't, we released a lot of software around two-way texting so that I can walk somebody through a questionnaire or a check-in or something, even if they have a flip phone, for example. But if we don't engage the patient where they are, which, let's be honest here, most of us kind of live right here with the screen in front of our face, then we're missing that opportunity, and the patient wants to be there with us.
I couldn't agree with you more. My 10 years with Sonar now, we do exactly what you've just described. We send out what we call Sonar pings, which are little snippets of symptom-related questions that bring back a symptom score to us. And we have very high patient engagement rates, over 80%. The patients do like this. They feel more important when they're proactively reached out to. And I think the reactive structure of medicine, where providers are just constantly waiting for people to reach out to them with symptoms, has to be replaced by more of a proactive system. I'm very happy when you gave me that answer at PTAC, because it is exactly where I think we should be. We're running down on time here. Let's talk a little bit about quality measures. I want to make sure I cover that. So where is Epic with quality measures? I hear from CMS all the time that it takes 5 years to get a quality measure out there, and then after that 5 years, it has to be implemented into an EHR. How versatile are you in being able to create these quality metric fields? How do we get these more implemented?
Yeah, so we support all of them. We wish we had fewer to support. And I would say because I can't say to somebody, I can't support that measure. Sorry, that's just not the world that Epic lives in. So we support them. But I think we're letting everyone define things differently. And that's a very American thing. Like, we have to have the freedom to have these discussions and define what's right for them. But when I look at a measure where one definition is a year and another definition is in the last encounter, we have to get together on that. And I don't like to say the government needs to solve this for us, but I do think we need a forum that spans agencies across HHS to say, we're going to pick one thing to do, we're going to put it in place. A lot of times these are 49, 51 decisions that last far too long and cost everybody far too much. Because even if I develop it, somebody else has to put it in place and support it. There's an administrative burden. I'm going to make some doc enter one more field, and that's not great, right? So I think we need to stop outsourcing the decision. We need to get the right players together. No one group can make this decision, and stand behind one definition of something like breast cancer screening that we should have a definition for. We should not have 20. And that's what we have today at a minimum.
Boy, you're speaking to the choir, preaching to the choir here. That's exactly where we have to go, and we're trying to go there at PTAC. Last question. Rub your Epic crystal ball. What does the future of AI, of EHRs look like? How does AI fit into this? I realize this is an easy answer, so you'll have no trouble.
Yeah. No, it's I'll give it my best shot. Like anything, EMRs have to constantly innovate or be left behind. I think the interesting balance that we hear is, on one hand, we hear we got to move faster on this, our docs need it, or then we can't manage the volume of this change. So I think success is threading that needle, and most importantly, doing it in a manner that human change can happen without significant abrasion. Now to AI, right? It's 2024. AI is super exciting. I think like most people, I have two or more minds on AI. So first, AI has existed for a long, long time, since the first time we were pushing printed cards into a computer. That's AI. That's logic-based artificial intelligence. What we're talking about now is neural nets and generative AI. I'll say this very shortly. It's got to make our life easier. That's the promise. We need to consider ethically how we do it to make it transparent that a computer is doing something and keep the human in the loop. This should reduce our cognitive burden. Like I like using GPT to draft me something. Here's 5 to 10 data points, give me a summary of it, and then I take it and massage it. Can you imagine if AI just sent an email off for me? That wouldn't be great. So we want to make sure the human is in the loop. And AI is going to make us faster, but it's all of our responsibility to make sure that it's safer. And that's why ethics comes first in how we approach this. I'm very cognizant of AI being implemented without a thoughtful approach of the human being in mind, ethics being in mind, and transparency being a focus.
Love it. Easy, ethical, humanistic. Love it. Love it. Well, thank you very much for being on the show today, Nick. This was really a great show. I could have talked to you for another hour. Okay. And maybe you'll get down to Scottsdale and we can physically get together.
Looking forward to it. Thank you, Dr. K.
All right. Anyway, thanks to everybody. Thanks to the audience for tuning in. You can access our podcast on most all of the podcast platforms like Apple Podcasts, Google, Spotify, and others. Learn more about the show on the programs page on healthcarenowradio.com. Lend your voice to the conversation on Twitter at HCNowRadio. Be sure to follow us on Twitter at SonarMD. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.